Thank you very much for this immense honor of asking me to deliver the past President's oration. 2 years ago, when the ISCCM asked me to deliver the ISCCM oration, it was an immense honor, and I didn't think that this one would come so close to follow. And what makes this unique honor of having to give both the orations which are hosted by ISCCM is the fact that, as a coincidence, this oration today is on a day which is exactly 25 years from the time that we started the first critical care unit in Pune. It was on 16th February 1986, exactly 25 years ago to this date that we started the first critical care unit. And it's an honor that 25 years down the line, I'm standing here with all of you to deliver this past President's oration. Over these 25 years, when we look at the journey, we realize that I need to discuss not just the challenges of a ICU patient in India, but challenges of critical care practice in India, because I think that's more pertinent, because more than the patient, the whole system, the environment, the atmosphere, the other issues related to critical care, they blend so much into the practice of intensive care that rather than just discussing the challenges of an ICU patient, I thought that I would modify the title and discuss the challenges of critical care practice in India. When we started 25-30 years ago, we realized that the traditional medical centers in the country were saving lives more through dedication, a lot of common sense, and a scientific approach which was inculcated in a clinical practice. The practice was predominantly clinical, the diagnosis was predominantly clinical, the approaches were more based on eminence rather than evidence, but the whole thing was merging into trying to make a very sincere and serious attempt to save lives. And we were also struggling in that period with the peculiarities of life in India and its contrasts in every aspect. And these contrasts were also merging into our practice in intensive care. In 1992, we started the Critical Care Society in Pune, and in 1993, when some of us got together to form the Indian Society of Critical Care Medicine, we didn't realize that in the years to come, this would become such a strong, united body of professionals with more than 5,000 members and almost 50 city branches. So the journey has been exciting. The journey has been made possible by a strong single commitment to making sure that the lives are saved. When we began the new adventures in 1993, we realized that there were lots of challenges. The challenges were different. The challenges were partly unsurmountable, it seemed at that time, and the challenges were encompassing a lot of issues. The first and foremost was the struggle to establish a new specialty in India. Its acceptance to our hospital authorities, its acceptance to our colleagues, its acceptance to our patients, and its acceptance in the society at large was a difficult issue. Its importance was there in our mind, but the importance needed to be translated into actually trying to save lives and prove ourselves and prove the worthiness of a critical care service in a hospital settings. Our resources were pretty limited, both in terms of financial resources, equipments were limited, our ideas were strong, enthusiasm was quite great, but to translate that into effectively saving lives, we needed also enormous amount of resources and manpower, and that was a huge issue at that point of time. And also amongst the initial struggles, we realized that our attempt needed to show to the medical world in India that we needed to de-link the coronary care units from the critical care areas. Although we started off with merging of the two, over a period of time, the importance of critical care grew, and we could finally establish ourselves to de-link from the coronary care units. The initial challenges also included attempts to standardize the education. We realized that if we wanted to develop the manpower we needed to make sure that the younger generation needed education in critical care. And when we approached the Medical Council of India, we were thoroughly rejected because we were told that it was not necessary at that point of time. I know that you are all aware that over a period of time this dream has also come true, and very recently the Medical Council of India has accepted critical care as a super speciality, which will lead to the formalization of training in DM in critical care. Our challenges also included attempts to shift age-old ideas. For example, when we started ventilating patients in the critical care units, we were initially told that, look, mechanical ventilation needs to be started on patients only towards the death, and probably it won't work, and probably it doesn't mean anything, etc., etc. And our die-hard attempts actually were very strong in order to shift these ideas and prove ourselves. One of the early challenges was also in our interaction with other specialties. And although we realized that we needed to be close to them and we needed a close, unified interaction, they were too willing to make sure that in trying to come nearer, they were wanting to swallow us. And therefore, this peculiar coexistence of wanting to interact with our colleagues in other specialties, take their help, and at the same time prove our own merit was also a special challenge in that period. Gradually, the shift of accepting a new specialty came into reality over a period of time. People started accepting that critical care is a different branch. It needed different skills. It needed different mental makeups, hard work. And it wasn't just an area of a hospital which had specialized equipment. They realized that the manpower is making a difference in the outcome of patients from intensive care units. So this has shifted now, ladies and gentlemen, and as you are very well aware of, our current challenges in 2011 are different from the challenges that we faced in the initial era of critical care services. One of the major challenges which we have always felt over the last 15 years has been the collection of data in Indian critical care units. And I'm very happy that with the participation of Indian ICUs in data which started a few years ago through the SAPS-2, in various international trials we have participated in the contribution of our data to the international data, and we have now formalized to form our own data in terms of the ISCCM data bank in INDICAPS. And this is a very large study which is including 316 institutes all over the country. And very soon, over a period of time, we will have a huge database on patient demography, the type of patients which are coming into the intensive care units, the severity, the outcomes, the usage of treatment modality, withdrawal of life support, and so on and so forth. And I'm sure we are all looking forward to the excitement of the generation of our own data. Amongst these data, of course, will come probably the biggest challenge that we face today in our country, and that is the antibiotic-resistant strains which are currently harboring our own intensive care units all over. We know that India contributes very significantly to this global invasion and global escalation of the ESBLs, and we have now definitive data from most of the good centers of the country, initially starting off from some isolated studies generated by the pharma industry, but then crystallizing into the acceptance that we need our own data to make sure that we understand what the antibiotic resistant strains are. And although ESBLs and the gram negatives are our current major bugbears, we are also expanding into the areas of looking at a lot of MRSAs, resistant fungal infection, enterococci, and so on and so forth. So it is probably the country's biggest challenge in the field of intensive care units. And when we look at patients coming into the ICU with severe sepsis, we realize that there is a fundamental truth in what we are trying to attack, and that truth is probably we are facing a patient of severe sepsis caused by infections which are multi-drug resistant. This leads to our attempt to make sure that our anti-infective treatment has to be at a higher gear, and unfortunately that tends to escalate the antibiotic resistance. So currently we are caught into a web where in trying to save one particular life, we are escalating the antimicrobial therapeutic regimens, and in trying to do that we are putting all other lives at stake by creating drug-resistant strains. So it's a vicious circle, and this vicious circle is existing in the majority of the intensive care units of this country. And time has come for us to look at this extremely seriously and make sure that we attack this and break this vicious circle at some point of time. All of you must have read about the huge cry which has been made by the New Delhi metallobetal activists producing gram negatives, made by the Western world, starting off from the Lancet publication and then escalating into the media as well. And although we know that these kind of carbapenem resistant gram negatives are not different from many that we are seeing, and this is the data from Hinduja which has been published in the JAPI. It showed that the carbapenem resistance amongst the ICU gram negatives has been increasing over a period of time. And all of us are aware of it, whether we record the data or not. But it's just that its wide publicity which came up into the Western world make us sit up, look at it more carefully and make sure that if we want to salvage our patients from succumbing to this carbapenem resistant gram negatives, we got to do something very seriously. We all are aware of the clinical relevance of the resistance, and we are all aware of the fact that the two single most reasons for the production of the antibiotic resistance are antibiotic exposure and inadequate infection control measures in our intensive care units. And I think if we want to challenge this major problem, we need to challenge it on both levels, at the level of appropriate antibiotic exposure and inadequate infection control measures. If you look at the overall medical practice, we realize that majority of the doctors beyond the scope of intensive care are not as much aware of the catastrophe of gram negative or other antibiotic resistant problems. And they just tend to use antibiotics extremely indiscriminately, irrespective of whether its needs are appropriate or not. So no matter how hoarse we try and shout by saying that when we use antimicrobials, we need to be defining them into appropriate classes of being definitive, empiric or prophylactic, you tend to keep seeing these prescriptions of antibiotics which are extremely irrelevant and extremely irrational, and that tends to upset us in the intensive care units. And this is just one example of a recent referral which I got from a very established diabetologist of the city, someone who has been on an international panel of experts and who has been a faculty member in all the diabetology meetings of the country. And look at what he has written. Dear Shirish, Mohan seems to have viral fever, bronchitis and gastritis. He was admitted in a nursing home in Mumbai and has just returned. I have advised him admission IV antibiotics and fluids. And this is the concept that our colleagues are tending to harbor, that they're making a diagnosis of viral fevers and they're also advocating IV antibiotics and the same blood. So I think these kind of mindsets in all our colleagues need to change, and if someone needs to change it, we need to change it, because it is affecting our specialty in the predominant zone. It is we who are going to face the brunt of the antimicrobial resistant strains in the intensive care units. And if we want to make a difference in the outcome of our patients, I think we need to start at the grassroots and make changes in the antibiotic prescription levels of all our colleagues in the community. We also know that there are some other factors which are beyond our control, and these include the poor quality of antibiotics, which has been defined by both the WHO and the CDC as being one of the major problems of the developing country. And this poor quality of antibiotics stems these kind of observations seems to come from very appropriately studied data that poor quality and reduced potency antimicrobials are on the prowl in the intensive care units and in the community in the developing countries. And they have also defined what are the reasons for these poor quality of antimicrobials in terms of counterfeit drugs, adulterated drugs, drugs with bioequivalence which is not adequate, drugs which have been manufactured somewhere outside the country and brought into the country and being sold in this country at a cheaper price, and so on and so forth. So these kind of wars of inappropriate antimicrobial therapy are probably beyond the fights of all of us as clinicians. But what probably still lies in our armamentarium is to make sure that we reject them at an appropriate point of time when we face our patients. So if we are firm and say that we reject such kind of medication, then probably we'll have contributed in some might. I'm also aware of the fact that many hospitals have these policies of taking the drugs only from their own pharmacies and formularies and stocking agents which are of dubious quality in those pharmacies, primarily for the sake of economic gains. And that is a huge challenge for us, and I'm sure, I'm quite aware that we as clinicians will not be able to fight these kind of challenges. But I think if we can do our might by showing our resistance to the use of certain such molecules, we will have done our bit. So the non-standardization of manufacturing processes, if we show our resistance to this, this is going to be the key in control of antimicrobial resistance. And of course, the infection control practices need to be heightened. If there is one thing which we all can do in order to stem the problem of antimicrobial resistance in our ICUs, that is to control the infection control practices and improve them. I think it is time that we all sit down in our own ICUs and look at the way our staff is handling these patients, managing them, and make actual appropriate gestures which will improve the infection control practices. There are too many sites and inanimate objects in our intensive care units which can harbor these antimicrobial resistant strains, and therefore it is appropriate that we sit down in the ICUs, look at all these with wide open eyes, see for ourselves, be critical of ourselves, and make sure that we make changes in the ICUs which will make sure that such kind of infection control practices are improved. So the key to control antimicrobial resistant pathogens in our ICU will turn out to be on two pillars again, that is the prevention of antibiotic misuse and rigorous adherence to infection control guidelines. And I think it is here that forms like these could be very interesting and important. This is a form which most of the family physicians have to hand over to an American patient, and it's quite interesting. It's an outpatient form, and it says that instructions to the patients which include: you have been diagnosed with an illness caused by a virus, and antibiotics do not cure viral infections, so we are not giving you any antibiotics. And then there is a list of what they should be doing, and at the end they say that if you are not better or if new symptoms come up, please come back to us so that we will reassess the decision of not giving you any antibiotic. I think such kind of practices need to start at our community levels in order to make sure that at some point of time the antibiotic resistance is attacked by all of us. And I think our next biggest problem is our issues related to tropical infections. We are all aware of the list of tropical infections which continue to harbor our intensive care unit, and the list continues to grow with the recent Crimean Congo hemorrhagic fever and isolated examples of Japanese bee encephalitis which have been documented. And maps like these where we show a large number of cases of patients with arthropod-borne viral infections and increasing data on patients suffering from dengue, they tend to alarm us. Unfortunately, the data that we tend to generate in this country regarding the occurrence of these tropical infections is not an appropriate and adequate and accurate data. First of all, take the case of dengue, for example. It's a disease which is not easy to diagnose because the methodology of making a diagnosis is on the basis of an antibody response, and the sensitivity and specificity of tests which are used to make a detection is questionable in different kits which are available to make a diagnosis. On top of that, the public health authorities make sure that we underplay the diagnosis because they tend to tell the patients that, look, there is no dengue. We have had such examples in Pune where the public health authorities made sure that the patients accept the fact that this was not dengue, just to make sure that the reporting will increase their workload. So a huge amount of back pressure from the public health authorities is tending to undermine the accurate depiction of the data in relation to dengue. But be that as it may be, in our intensive care units, I'm sure we can formulate, and when the INDICAPS comes out, I'm sure the next step would be to make sure that we get appropriate data on our tropical infections and then formalize strategies to make sure that the deaths due to these tropical infections are reduced to a large extent. So our false perception of low disease burden needs to be changed in terms of making sure that our diagnosis is better. Also for malaria, we need to make sure that we have an appropriate documentation of the data as far as its diagnosis is concerned and its mortality, and the large number of deaths which still continue to haunt us in our intensive care units need to be attacked. The species is tending to show variation. We now see more and more of vivax coming into the intensive care units with slightly different presentations as well. And unless we have data and unless we attack it in a uniform manner, I don't think we are going to alter the mortality caused by this biggest killer. If you look at it in a slightly skeptical manner, the WHO report indicates that 4,000 to 5,000 patients die every day in the world due to malaria, which means that during this 30-minute talk, about 100 human beings will have died due to malaria. And that's a staggering figure. And if we want to attack it as far as India is concerned, I think appropriate diagnosis and making sure our intensive care practices are appropriate to tackle this are going to be the key. During the monsoons, we tend to see a splurge of a number of other diseases. And in Pune recently, we had not just the malarial infections and the dengue infections, we also had a large spurt in H1N1s as well. And the H1N1s made such a hue and cry on the media that the medical facts tended to get submerged. And not just the facts tended to get submerged, but also strategies therefore to contain the disease and treat those unfortunate ones which reach the intensive care units tended to get a low priority. So the story of H1N1 in Pune ran like this, that we saw a large number of cases and deaths, but there was unfortunately an inaccurate reporting both in terms of ICUs as well as the community. It just made a mass care which was heightened by the media and the current strategies which are used by the media, and the poor management by the public health authorities, poor distribution and segregation of the affected patient and poor information to general public only heightened all this. And of course our healthcare system is structured in such peculiar manner that triaging these patients for appropriate treatment like HFOV or ECMO cannot be done in majority of the situations. And therefore, it overall turns out to be a class example of how not to manage an epidemic in the Indian scenarios in today's world. Of course, one of the major challenges which we still continue to face in our intensive care units is the problem of inadequate resources to manage a system which is already grossly overburdened. And I've shown this in my old presentations about the economic differences between the Western world in terms of the GDPs, the health expenditure, and not just these, but the contribution of the third-party payments or the insurance payments in terms of the health expenditure. This means that the predominant burden of bearing the cost of intensive care will fall on the patient's own pocket, and this will be a huge limitation in terms of practice of intensive care in our country. And it's not just the ability to pay, but in some it is the attitude to pay which is also a key in terms of making sure that the appropriate treatment is not given. There is a city in my state of Maharashtra. That city boasts of the largest numbers of sales of Mercedes in the country. And that city, people can just go walk across and with the cash stuffed in their pockets buy a Mercedes-Benz E-Class. And these are the same kind of people who would refuse to pay appropriate amounts which are spent in the intensive care units by a dedicated team of doctors and nurses. So it is this attitude of the patients when they are trying to pay from their own pockets, which is also coming in the way and which is a big challenge in our practices. I also sense a current shortage of manpower in intensive care, and my colleagues are also voicing that both in Pune and outside Pune. And I think we need to address this problem quite seriously, otherwise it will escalate into a major issue when we tend to grow old and when we have no one else to look after this second batch of generation. The Americans realized it way back when they looked at the number of people who were taking this super specialty training in critical care. And as soon as they realized it, they decided to have this report to the Congress in terms of what the critical care workforce is. And they realized that the aging US population is going to increase over a period of time, and the demand for intensivists vis-a-vis the availability of the intensivist is going to increase but show a divergent trend, and which will mean that a large number of patients will have inadequate critical care services. And I fear that the same wave is coming over onto India. The reason for this fear is that the number of intensive care units have grown, primarily because the number of hospitals have grown and they always view intensive care as a lucrative part of their business. And because the number of units have grown, we are not producing intensivists to the same number as compared to the need of the population or need of the society. So our critical care workforce shortage is currently a major issue and will continue to haunt us over the next decade or so. And it's not just the manpower in terms of medical practitioners, but it's also in terms of nurses and technicians. So one of our challenges in the ISCCM is going to be to make sure that we erect teaching programs in order to reach out to the population and make sure we have a large workforce of people wanting to come in. The current trend in the mindset of the young doctors is also coming in the way. Intensive care initially was looked upon as a serious but lucrative career, but unfortunately is looked upon more as something which is lucrative but is too demanding, and therefore there are other areas where the young doctors are tending to drift. And this is going to be a major challenge in our intensive care units over a period of time. We have no concept of erecting referral centers in our community, and therefore our hepatic transplant, our patients needing higher end services like hepatic transplants or ECMOs or HFOVs do not get segregated into appropriate zones. Our referral is predominantly in terms of a vertical or a horizontal referral, and therefore our ability as a society to handle such high-end issues will always remain limited and will always be a challenge. Our intensive care units predominantly are open units for economic reasons, and therefore the challenge and the fight between the obvious advantages of closed units versus the economic realities of open units is going to be a major struggle and is going to be a major challenge over a period of time. Our administrators' ability to understand the actual needs in terms of services in critical care, the applications of critical care, the need, the problems, etc. is quite limited. Our interaction with colleagues from other departments and their ability to understand us and listen to us is also limited, and their attitude in a changing societal environment is also coming in the way of being a major challenge. Our challenges also include challenges related to end-of-life issues. The Indian population is becoming an aged population like anywhere else because we are tending to save lives. And there are no current defined guidelines which are coming from regulatory authorities. We in ISCCM, under the leadership of Dr. Mani, had devised some wonderful guidelines, but unfortunately our practices are completely variable as per the interpretation and conscience of the treating doctors. So we have no well-defined policies, and probably the best method which is being followed is economic exhaustion as a major cause of defining the inability to continue as against the medical necessities of discontinuation. So we're not sure what is the current moment for withdrawal of life support or withholding of life support in our patients. We are tending to choose endpoints which are not really appropriate, and therefore our practices at the end of life in our community at large are not appropriate as they should be. And I think over the last 20-25 years, we are also tending to see a large burnouts. These burnouts are seen both in staff, colleagues, and also in self, I must admit that. And if you look at the literature, we see a large number of intensivists and the nursing staff suffering from burnout, and I'm sure as the specialty grows old, it's now 17 years, 18 years now, and over the next few years you will start seeing a large number of our old colleagues suffering from these burnouts. We also have a peculiar lack of medical audits and standardization of healthcare practices, and although the accreditation boards have now started moving in, we still lack a well-groomed system to have appropriate medical audits in our hospitals, and that is coming as a major challenge in trying to define what our challenges are and how best are we going to address to these issues. And of course, to compound all this are the overall influences of situations in the society, which include corruption, the lack of healthcare policies, the social beliefs, the peculiar mix of our lack of infrastructure and the politics. And all this, although sounding quite different and away from our healthcare practices, tends to have a huge impact on the way we run the hospitals and we practice critical care services. So it is time, ladies and gentlemen, that we stand up and take things in our own hand and be critical. We need to analyze, and with the help of appropriate data like the INDICAPs, which will come out in a few months' time, I think we must have a handle on what are our problems and how best to address that in the current environment that we face. We have really achieved something over the last 15-20 years. We have established a new specialty, we have disseminated knowledge, we have made advances in the available facilities, we have made definite reduction in mortality in certain diseases like tetanus or organophosphorus poisoning, etc. And we have made available a reasonably good quality of critical care at extremely low cost as compared to the Western world. So these have been our significant achievements over the last 15-20 years. But we cannot rest on only all of them, because our problems and challenges continue to grow. And our future directions, therefore, need to not only have the standard, reliable nationwide data, but a scientific analysis of our peculiar problems in terms of both tropical infection, antibiotic resistance, and so on and so forth. And therefore, good quality teaching programs, developing new trained workforces, and dissemination and improvement in standards of care is the way to go. And I'm sure Indian society, as it has done over the last 18 years, is going to lead us into that direction. Above all, I think we must all go back and make sure that we pledge to the reduction of antibiotic utilization and antibiotic resistance all over the country. If not, a time won't be too far where we'll be facing the serious issues of antibiotic resistance. So we know that our situation is extremely peculiar. We have our own methods of running this country in various fields and various ways. And the same thing applies to our intensive care units. And the same thing applies to our medical practice as a whole. And I think it is time that the perception that India is a working anarchy needs to be changed, and the perception needs to be passed on that, okay, maybe that it's an anarchy, but it's an anarchy that works. It has worked over the last 15, 20 years, and it has saved a lot of lives. And it is time that we look at it from a very positive perspective in order to make sure that this continues in the future, in order to make sure that we devise our own methodologies and deliver despite the challenges that we continue to face in our intensive care units. Thank you very much.